appropriate arterial blood gas values and really some differential diagnoses. So case one's a 40-year-old healthy woman who's coming in for breast biopsy. She's average build, but very anxious. Blood pressure looks good, 120/80. Heart rate slightly high at about 80 beats per minute. Respiratory rate absolutely normal, 12 beats per minute. She had a normal physical exam, and the plan is to give her intravenous sedation with local infiltration, again for her biopsy. So the procedure starts out in the OR with a blood pressure cuff, ECG, and pulse oximeter. And at this point, the sedation begins, and SpO2 falls to 95%. So one of the things we're getting at here is the SpO2. This means the pulse oximetry derived data. It's not arterial blood gas, and so we see that here. Here's a pulse oximeter machine, again showing overall 95% is her oxyhemoglobin saturation. So SpO2 is a pulse oximeter 95%. So what to do next? Should she be intubated? Should you give her supplemental oxygen, reduce sedation, or observe? So if you want to pause your lecture here, you can and think about it. And when you have an answer, you can start playing again, and we'll continue to work through the case. Okay, so probably necessarily wouldn't intubate. I think any of the next three options are fine. Again, overall 95% is not a huge drop. It's not terrible. Again, certainly you want to observe her. You could give her some supplemental oxygen, perhaps decrease sedation, but again, necessarily probably wouldn't want to intubate it at a hemoglobin saturation at 95%. So at this point, what's applied is 4 liters of a nasal cannula, and SpO2 returns to 99%, so that looks good. There's now some pain on local infiltration, so this leads to opioids and increased sedation of the patient. Further moaning of the patient leads to more opioids. About 15 minutes later, SpO2 begins falling rapidly, and at this point, patient is apneic, is no longer breathing, so complete cessation of breathing due to and consistent with a falling SpO2. So what to do now? So apply a mask with 100% O2. You can mask ventilate with room air. You can intubate at this point, place the endotracheal tube, put the patient up with a positive pressure ventilator. You can ventilate the patient with an ambu bag, or you can do mouth-to-mouth ventilation. So at this point, again, if you want to pause, think about what you might do, and then start playing again. So really, as it turns out, options 2, 3, 4, and 5 would all be appropriate. Option 1 would not. So why not giving someone 100% O2? Well, if they're apneic and they're not breathing, putting a mask on them with 100% O2 is not going to do anything. Unfortunately, they can't breathe it in. You need to do the work of breathing for them. They're simply not they're not ventilating, and so putting, again, oxygen, supplemental oxygen only works when the patient is breathing. And in this case, again, the work of breathing has to be done for them. So either of these 4 options, where you can mask ventilate, you can either hook someone up to a ventilator and have do the work for them. You can put an ambu bag on them and hand squeeze the bag and ventilate for them. Or some devices you can actually do a mouth-to-mouth ventilation and breathe for them. So the important thing is when someone is no longer breathing, and although supplemental oxygen is very good, it's highly therapeutic. Again, but the important thing, it only works when the patient is breathing. So let's just kind of go through that. So why would you not want to give 100% O2? So we can go back to our friend, the alveolar gas equation. So as we previously talked about, we know it's always 760. If you're giving someone 100% O2, that means your FiO2 is 1 or 100%. So it's 760 minus 47, which is 713. Times 1 is 713. We now plug this in. 713 minus 40 over 0.08 means alveolar O2 in the face, or in the presence of 100% supplemental oxygen, your alveolar O2 is 663, which is very good. So that would help someone who, in fact, has a decreasing SpO2. But the problem is what do we know about alveolar ventilation? So it's tidal volume minus dead space times respiratory rate. Again, normal alveolar ventilation should be about 4,200 mLs per minute. But the problem, the patient is apneic by definition. Respiratory rate is 0. So it doesn't matter what the volumes are. 0 minus 150 times 0, so it's 0 mLs per minute. So again, this is bad supplemental oxygen. Again, does not work if your patient is not breathing. And again, the alveolar gas equation indicates the importance of how supplemental oxygen is good in getting PaO2 up. But again, the alveolar ventilation equation tells us that when again your respiratory rate goes down, essentially ceases altogether. Again, you have no alveolar ventilation, so certainly supplemental oxygen is not going to work for you when when a patient is not ventilating. So as it turns out, capnography is telling in this point. So if you were to look at a machine, for example, and look at some different values, this is the SpO2. So SpO2 is not that bad. It's indicating at this point in time it's 88%. And so overall, we see EKG and heart rate's okay. Again, hemoglobin saturation is okay at 88%, but here's our capnography, and so here's our capnogram. We talked about the waves, and so here's our peak end tidal CO2 volume. Here comes the next inspiration, and it ends up coming back down. But the question is, what do we see here? And unfortunately, we don't see any more peaks coming along, no more CO2 peaks coming along. And so what this is telling us is the patient is to stop breathing. And this is something we'll talk about more about the regulation of breathing, but the reason why we're breathing is to blow out CO2. So overall, again, we have to be careful with is we think a lot of times we breathe to bring in oxygen, and really the reason why we breathe is to blow off CO2. And so in one sense, the pulse oximetry, again, it can display a value that doesn't look all that bad, and you may again, look at this and say, well, the patient could be doing okay, but again, it's the capnography that's telling you something is clearly wrong in the patient. There's a cessation of breathing, and at this point, you have to start doing something to breathe for them. They're unable to breathe on them by themselves, and again, the last thing that you want to do to this patient is give them supplemental oxygen, because again, what this indicates is they're not breathing. So again, this slide is important. It illustrates capnography tells you whether or not someone is breathing, not necessarily the hemoglobin saturation, again, that you can derive via pulse oximetry. And again, this is clinically, this is apnea, cessation of breathing, again, and it's kind of screaming out that something's wrong here. And again, that's picked up by the CO2, not by the O2. And so what's a common percent of oxygen that's given therapeutically is about 40%. And so then the question therefore is, if you give 40% in FiO2 of 40%, what's that going to translate to in terms of what your arterial blood gas should be? So if you want to get pause here, you can do the calculation. And again, it's simply the question, if you give someone supplemental oxygen, the FiO2 is 40%, what would you anticipate arterial oxygen to be? And you can pause, and when you're ready here, resume playing the lecture. So as it turns out, when we do the equation, it turns out it's about 230 millimeters of mercury. So this is kind of a common, again, rule of thumb. If you give someone 40% O2, you should get arterial oxygen up to about 230 millimeters of mercury. And if you don't, for whatever reason, that, again, is going to indicate clearly that there's some kind of problem going on. What this tells us, too, as far as oxygen saturation goes, if this is 100 PaO2 of 100 millimeters of mercury, and again, we're about 98% saturated, if we could extend or extrapolate this line out here to 230, certainly we'd be 100% saturated. So giving 40% O2 should get arterial PaO2 up to about 230, and again, that should get hemoglobin saturation up to 100%. And again, this is a common option that's used, and again, just understanding when that's applied, what position that would put you at, again, with respect to your PaO2 value and respect to your hemoglobin saturation value. And overall oxygen content should stay at about 20, doesn't really go up significantly, and the reason why is we're at this plateau. And so again, understanding that content would certainly be maximal at this point, again, about 20 mLs per deciliter of blood. So here's case 2. So you respond to a code blue on the medicine floor. It's a 70-year-old thin male. Alarms are going off. He has no vital signs. So you start chest compressions are going on, they're occurring. You're handed a laryngoscope to intubate the patient, to place in a endotracheal tube. So the tube goes in relatively easily, which is a good thing, and but there might be a problem here. And so the problem, there's no color change. So the tube has now been placed into the trachea of the patient, and the chemical device is placed on here. You're waiting for the color change, and you're waiting for CO2 to pass through here, but you don't see any. And so the question is why? What are some possibilities as to what's going on? And so either one of two things or one of four things, options, is either the tube is not in, chest compressions are ineffective, the device could be faulty, or any of the above. So what could be an explanation for the appearance of no CO2 in the chemical device? So really, the answer is it could be any of the above. If the tube went into the esophagus and not the trachea, you certainly would not have CO2 coming out. Chest compressions could be ineffective, and they're just simply not assisting in helping the patient. The device could be faulty. That piece of paper that changes color, sometimes they generally work almost all the time, but again, they're not absolutes. So any of those could be problematic with the problem with this patient. And as it turns out, though, an important thing to understand is when we think about ventilation, again, we talk about the expelling of CO2 out of the lungs, and obviously the lungs are critically important for that. But keep in mind, the important thing about this is the CO2 is in fact derived, it's made down here in the tissues. This is its source. And the only way how it gets to the lungs is through this cardiovascular system. It has to be transported to the lungs. And so the critical point to understand from this is if there's no circulation, if there's no pulse going on, essentially there's going to be no end-tidal CO2. And this is again, it's just a caveat to, again, just while the lungs are critically important for blowing off CO2, similarly, if we do not have circulation to bring that CO2 back, it's going to look like the patient is not breathing. It's going to indicate that perhaps there's an apnea, and again, that the patient might be breathing, but if no CO2 is coming into the lungs, ultimately, again, you're not going to get a reading on that. And this just underscores that in addition to having good pulmonary function, we actually need pulmonary circulation, and really the systemic circulation, but certainly the pulmonary circulation, to get the CO2 from the tissues, bring it up in, deposit it in the lungs, so now it can be blown off. And again, just that underscores that point that not only lungs are important, but certainly the circulatory system is equally important in making sure that we can blow off CO2. So lack of CO2 could be a potential that we're apneic, we're not ventilating, or there might be a lack of circulation in a patient. So just keep that in mind. So the last case 3, is a 3-year-old child is brought into the ER from a house fire. The patient is unconscious, but the intubated girl of an average size. The SpO2 is 100%. So this is the pulse oximeter indicating 100% saturation. Heart rate's 190 beats per minute. Perhaps a little bit high for a patient, but considering she just came out of a fire, and blood pressure is 80/50. And so what should be done to ensure that there's adequate gas exchange in this patient? So 4 options here. So nothing, there's good, that the SpO2 is good. It's certainly at 100%. So you can observe and the respiratory rate and look for chest excursions. You can check for exhaled CO2, again, something using capnography. You can draw an arterial blood gas value. So again, which one of these would ensure that there's adequate gas exchange taking place? So if you want to pause here and think about it, you can. And when you're ready to go, again, you can hit your play and start up again. So as it turns out, probably one of the best things here, we alluded to this a little bit earlier, that Pulse oximetry, again, it's a good estimate of what values are, and even to some extent capnography. Let's say if you're a side stream or the chemical paper, again, sometimes the paper doesn't work. And really the best way is if you have access to it is arterial blood gas values. They never lie. They're the most accurate, but again, they're challenging, and you may not be in a position where you can always draw those. Probably the best thing here is to get draw on arterial blood gas values and see what they say. And again, those tend to never lie and will be pretty good indications of the status of a patient. So for all the patients, ABGs is pH is 7.4, which is normal. CO2 is 40, which is normal. O2 is at 391, but that's with a patient getting supplemental oxygen is not it would be consistent with that. Bicarb is normal at 24, but the arterial O2 is at 65. And so what's going on here? So 65%. So this is saying the saturation measured in arterial blood. So this is the oxyhemoglobin saturation coming from arterial blood gas is 65%. But remember, a couple slides ago, the pulse oximeter said it was 100%. And so the issue is what is going on with this patient who just came out of a fire, who has actually a very high PaO2. So again, receiving supplemental oxygen has a PaO2 at a very high level, which is good. However, the hemoglobin is not being saturated. It's being down here at 65%, as measured by arterial blood, but yet the pulse oximeter had it up to 100%. So what is going on? So if you need to think about it, you can pause. When you're ready, hit play, and we can keep going. So the answer, again, really is if we think about this, and so at 391, so here's a PaO2 of 100, here's 600, 391 is somewhere here. Overall, definitely saturation should be up near 100%. And again, arterial blood, it's only down at 65%. We talked about some things that can depress saturation. The classic one is carbon monoxide. And so carbon monoxide, in fact, is a byproduct of smoke and fire. And so what you then have is a mixing of carbon monoxide and oxygen, moving into the lungs, moving into the blood. Again, normal oxygenation shown here is what oxygen can bind hemoglobin. But when carbon monoxide binds the hemoglobin and it competes with the oxygen binding site, oxygen is unable to bind. So this just underscores again how the pulse oximeter, in addition to the net hemoglobin, with carbon monoxide can be fooled. It's telling you it looks everything is good, but unfortunately the pulse oximeter cannot distinguish between carbon monoxide binding hemoglobin and oxygen binding hemoglobin. It sees it as one and the same, whereas the arterial blood gas can clearly differentiate that. So in the fact that the PaO2 is very high, according to the curve, should guarantee 100% saturation. The fact that it's only 65%, something is impeding the ability of oxygen to bind the hemoglobin. It's suppressing the saturation. Again, a classical thing, it can do that as carbon monoxide, and that would be consistent with something coming out of a house fire. So this then, to kind of finish up here, there's a couple key concepts of ventilation versus oxygenation. Ventilation, when we get to the understanding how we regulate our breathing, this will become clear, but ventilation really is removal of CO2. Oxygenation is the addition of O2, and they're really different processes. So we ventilate, and we really breathe to blow off CO2, but we more so than certainly to bring in oxygen. So we're going to talk about two different concepts of ventilation as the removal of CO2. Oxygenation is going to be the addition of O2. And both are most accurately measured in arterial blood gas, as we hopefully indicated this. Again, capnography is good, pulse oximetry is good, but again, just understanding what the caveats or the Achilles heels are to those measurements. But again, if you always want your truest answer, that's going to be within your arterial blood gas values. And so to kind of finish up then, at least to return to the oxygenation, so what determines the amount of oxygen in the blood? What determines our 20 ml of oxygen per deciliter of blood? Is it hemoglobin concentration? Is it the PaO2? Is it the saturation? Is it 1 and 2, 2 and 3, or all of them 1, 2, and 3? Again, you can think about it. If you need to, you can pause. And so it turns out really it is 1, 2, and 3. Here, the hemoglobin concentration, the PaO2, and the saturation are ultimately going to dictate what our content is. And so just remember, we go back to our content equation. It's hemoglobin plus dissolve. And so we look here. Here's our hemoglobin concentration. Here's our saturation is important. And here's the PaO2 that's important. And so keep in mind, hemoglobin concentration can be affected by disease such as anemia. It can be reduced from 15 down to 10. The saturation can be affected by carbon monoxide. So saturation can come down to 65%, even in the face of a very, very high PaO2. And carbon monoxide has the ability to decrease and displace the saturation, even in the face of a high O2. And it can do that because its affinity for hemoglobin is so much greater than that of oxygen. And of course, anything that lowers your PaO2, by definition, is hypoxemia. That could be a respiratory disorder. Something we know too. So if we decrease PaO2, overall, this is going to decrease the overall content. And we also not only the dissolved portion here, but a lower PaO2, for example, if it drops from 100 down to 60, we know that simultaneously the saturation would also drop down to 90, and that's from our 60-90 rule. So again, just what I want you to do here is understand the different variables of how we maintain our content and the different things that can affect that. And again, if we have a decreased content, where those things can be coming from. Again, the concentration plays an important role, the saturation plays an important role, and the PaO2 plays an important role, not only on the dissolve, but again, we know from our hemoglobin curve, the extent to which we saturate is entirely dependent upon our PaO2. So again, overall arterial content is derived by these three parameters. And again, this is simply a constant, the 1.34 mLs of oxygen per deciliter of blood. Again, this is the solubility of oxygen in solution. So in summary, the key points in understanding oxygenation is the addition of oxygen into our system can be accurately measured by arterial blood gas values. It certainly can be approximated with pulse oximetry. And again, ventilation is really the removal of CO2. It's again, we want to measure the arterial blood gas values, again, which is the most accurate way, but it can be approximated with capnography. So both pulse oximetry and capnography are good ways to estimate what ventilation is. And but again, if you really wanted to know it for sure and confirm it, you want to go back to your arterial blood gas values.